Thank you, Dr. Animesh, for this nice opportunity and for this conducting this beautiful conference. Good morning, everyone. So this is a very interesting topic. And as a resident, when I started my radiation oncology residency in 2007, I remember that PCI was like a standard of care for each and every small cell lung cancer which responds. And from that, in next 15 to 18 years, now we are in a situation where we are discussing whether PCI should be given in every patient or not. So of course, that means there are some developments, some evidences, and based on that, we are now debating or we are now discussing whether we should go for it or whether there is a subset of patients who merits it and there are other subgroup of patients who does not merit it, or there is a group of patients who for whom we can wait and watch and may use radiation later on to have a better neurocognitive effect. So before I begin, I have nothing to disclose. I have no conflict of interest, and my acknowledgement for Dr. Shikha Goel from PGI Chandigarh, Dr. Shobna and Dr. Binda Singla, my associate and my registrars, for helping me in making this presentation. So we all know that small cell lung cancer is a relatively smaller subgroup, which represents approximately 15 to 20% of the entire lung cancer. And most of the patients, when they present to us, almost 2/3 of them come with an extensive stage disease, and only 20 to 30% comes with a limited stage disease. This is one of the very aggressive cancers with a very limited survival in absence of any specific treatment. And even with all possible treatments, the survival remains gloomy. Only 2% or 3% of the patients are never smoker. That means it has a very strong correlation with smoking. Now, looking at the staging system, we know that this classical staging system of limited disease and extensive disease came from the Veteran Affairs group. And that's criteria for limited and extensive are very clearly defined. The disease confined to one hemithorax with local extension without any extrathoracic metastasis other than ipsilateral supraclav, and regional nodes are considered as limited disease only when it is possible to either resect or to be treated with a radical intent dose of radiation in a single radiation portal. Everything else other than limited disease is considered as extensive stage, including the metastatic disease. Now, if we correlate it with AJCC staging, then the limited stage disease falls within stage 1 to 3, and others fall within extensive stage. T3, T4 with multiple nodule also comes under extensive stage. So this is how we can see that how limited disease and extensive disease can be defined. Very small brief about the treatment. We know that limited stage disease, whenever possible, if it is possible to go for mediastinal evaluation, one should go for it. And if the patient is amenable to surgical resection, lobectomy followed by criteria for deciding adjuvant chemotherapy. So all patients should get adjuvant chemotherapy. And depending on presence or absence of high risk factors, one can decide about using concurrent radiation therapy, either in a concurrent manner or sequential manner. Medically inoperable patients should go for chemoradiation or SBRT, depending on the size of the tumor. Radiation, whenever possible, should be started as quickly as possible, if possible from the first cycle of chemotherapy, if not at least with the second cycle of chemotherapy. So largely, if we see that the treatment decision depends on performance status, so good performance status follows the standard of care. The patients with poor performance status, either 3 or 4, if it is related to the disease, then one can go for systemic therapy in a sequential manner. Radiation can be added with concurrent chemoradiation followed by completion of adjuvant treatment. Poor performance status because of other comorbidities can be discussed with the patient, and treatment should be decided in a case-to-case basis. So if we look at this ESMO guideline, the previous one, we can see that PCI was recommended for almost all patients when the disease responded or disease remains stable in case of extensive stage disease, if the performance status is good. Now, this only scenario was more than 70 years with frail condition. The standard was like PCI may be avoided, or very case-to-case basis, one should be discussing with the patient and take the decision. And we can see that starting from 1990s until 2015, multiple articles were published showing this controversy whether PCI should be used or not. So that means it's a long-standing controversy. Now, the question is why? As we all know that radiation given to brain can have a lot of neurocognitive effects. And there can be acute adverse events like hair loss, some fatigue, some chronic demyelinating effects like chronic demyelination, neurocognition impact, impairment. So these kind of put the PCI a little bit on the back foot with the advancement of treatment, particularly after advancement of immunotherapy showing benefit in small cell lung cancer. And in properly staged patients with MRI, the benefit probably is not that much. So with this background, the role of immunotherapy and MR surveillance came in. Now, what is the rationale? Why should we treat with PCI in small cell lung cancer? If we see the data at diagnosis, almost 10% of the small cell lung cancer patients will have brain metastasis. And if we use MRI at the presentation, then we can see that almost 25% of the patients will have a brain metastasis. 33% of the patients can progress with brain metastasis after they achieve a CR or after the chemoradiation is completed. That means there is a scope of adding radiation to the brain. And studies, particularly previous studies, definitely showed some advantage. So a retrospective analysis by Operin et al. Showed that 5.4% absolute benefit in 3-year survival by giving or not giving PCI. And in extensive stage, Slotman et al., they also showed that there is a benefit in terms of DFS and 1-year OS when PCI was added. And the recommended dose was 25 gray in 10 daily fractions. Now, in early stage cancers where patient develops CR after treatment without any other risk factors, whether PCI really gives any benefit is questionable, and also it is questionable in patients who are more than 70 years of age. Let us look at the data for limited stage. So in NCI protocols in 70s and 80s, the study, when they analyzed it, the patients with CR, they did fairly well compared to the group who did not receive a PCI. And the overall survival was also better with the PCI group. We can see that there was a 22% benefit in terms of OS when PCI was given versus no PCI was given. Brain metastases were fewer when PCI was given versus not given. Now, there are a couple of meta-analyses. Let us see what happened in the meta-analysis when CR was achieved. So 7 trials, the first meta-analysis published in 1999, which included 7 trials with almost 1,000 patients. And 86% of the patients were of limited stage. Second meta-analysis, which was published in 2001, 12 randomized control trials with almost 1,500 patients, limited stage in 5 trials, and other 7 trials included all possible stages. The dose was 24 to 40 gray. If we see the previous trials, the variable amount of doses were used, which ranged from 8 gray single fraction or 8 gray to 40 gray with different dose and fractionation. And if we see that the patients who achieved the CR, they did fairly better in terms of in all these studies, they did better compared to patients who did not receive PCI. So there was decrease in brain metastasis with a hazard ratio of 0.48. That means you can reduce by 52% brain metastasis. Improved overall survival in patients achieving a CR, hazard ratio 0.82. You can reduce, you can improve survival by 18%. However, in all these studies, the late neurotoxicity was not evaluated properly. A third meta-analysis where any kind of response were analyzed. 2,100 patients in 7 trials, PCI versus no PCI. Only 2 studies were extensive stage. 1 study were limited stage. All 4 other studies, they included all stages. And we can see here again that reduced brain metastasis for all stages. And there is an overall survival benefit also. It was also found that OS benefit was much better for the patients who presented with limited stage. That means there is a doubt whether do we really need to give PCI in patients with extensive stage. So this NCCTG pooled analysis where 4 phase 2 or 3 data trials were included with almost 740 patients who had at least a stable disease or better outcome after chemotherapy and chemoradiation. They gave a PCI dose either with 30 gray 15 fraction or 25 gray 10 fraction. And in multivariate analysis, they have shown that there is a significant improvement in OS for after giving PCI in younger patients with limited stage and patients who achieved a CR. And PCI definitely, you can see that there is an OS benefit at 3 year. We can see a 13% absolute benefit with hazard ratio of 0.61, which is significant statistically. And if we see the local limited stage and we see the effect of dose and fractionation, higher dose actually did inferior compared to the lower dose. Probably the benefit wins off if we increase the dose beyond 25 gray 10 fractions. Now, what happens with extensive stage? If we give PCI versus no PCI, landmark URTC study, this is a phase 3 randomized study with 286 patients. Primary endpoint was time to symptomatic brain metastasis. Various dose fractionations were used, and radiation started within 4 to 6 weeks after finishing chemotherapy. This study was highly criticized also because the imaging protocol was not standardized. It was mostly like individual choice. MRI was not included as part of clinical imaging with a lot of uncertainties. However, that showed benefit using PCI. However, the subsequent trials, when gradually immunotherapy and MRI came into picture, this benefit was not seen. And if we see the recommendations, all these bodies who recommended before 2015, where PCI was recommended as standard of care, is no more there after 2020. So NCCN after 2020 and American Society of Astro after 2019, they mentioned considered PCI or MRI surveillance. Considered PCI or MRI surveillance. Another Japanese studies also questioned the benefit of PCI in the similar situation, and they have found very interestingly that the benefit of OS comes only when the patients were not staged properly with a brain MRI. The moment patients were staged with brain MRI, the benefit of PCI actually is no more there. So it is probably the misdiagnosis or improper staging which leads to benefit by giving PCI. So now coming to the immunotherapy era, what happens? What is the rationale? Now we know that many of these immunotherapy drugs are now having good CNS penetration. So probably the benefit by giving PCI may also be achieved using immunotherapy. It can lead to delayed use of PCI so that the neurocognitive effect can be maintained for a longer time. And also giving immunotherapy can make the soil, like the brain cells, more resistant for developing brain metastases. So now how much evidence do we have? So Empower 133, where almost 11% patients have received PCI. However, this study was not meant to see the benefit of PCI. It was more to see the impact of atezolizumab. And we can see that adding atezolizumab is definitely beneficial. However, 11% of the patients in this trial also received PCI. Another study, Caspian, only 8% of the patients received PCI when durvalumab was added. Adriatic trial, it's phase 3 RCT, 730 patients, stage 1 to 3. So the patients after CTRT and PCI, if there is no disease progression, add consolidation durvalumab or tremelimumab versus placebo. So we can see that adding IO improves benefit in terms of OS. We are not sure whether PCI has any role to play here or not. Now the guideline says that in limited stage disease, PCI is recommended if there is no disease progression post-primary treatment. However, in extensive stage disease, no PCI recommended if immunotherapy is administered. PCI in extensive stage is only recommended if immunotherapy is not used or immunotherapy is not tolerated. So the evolving literature of using brain surveillance is also there. A couple of studies are underway, like Primer Lung and Maverick. And we expect that in coming days, these data will be more mature. The Maverick is a very interesting study where they are actually using MRI brain surveillance alone versus MRI plus PCI. It's a randomized phase 3 study. So we will be waiting for this result and we will be able to know whether PCI really helps in this subcategory of patients or not. So to conclude, I would say that as of now, In limited stage disease, it is difficult to refute PCI. The data as of now is very interesting and very encouraging. In extensive stage lung cancer, small cell lung cancer, if the patient is getting immunotherapy, one should not go ahead with PCI. The data is also encouraging. If the patient is not getting immunotherapy, then then PCI should be considered if the disease remains under control or there is stable disease or benefit with the treatment. The newer approaches of giving whole brain radiation, including hippocampus sparing, is used in many of these new studies as a standard of care. So probably one can consider hippocampus avoidance safely if that we cannot find any brain tumor within 5 millimeter of the brain ventricles or the hippocampus. And the role of SRS in small cell lung cancer is yet to be established. So that is why specifically I have not included that in my talk. So with this, I end here. Thank you so much.
Thank you, Dodul, for this within a very short time with the elaborate discussions regarding these controversies. So, one or two questions is allowed. Is there any question among the students and faculties? I think no controversy.
So are you doing hippocampal sparing for PCI?
See, I will not say I'm very adventurous in this, but as of now, my standard of practice is not doing hippocampus sparing. But because I am not doing, that does not mean it cannot be done. Because if we see all these latest trials, the phase 3 trials, they have allowed doing hippocampus sparing as standard modality. And my understanding about phase 3 studies are if any treatment is allowed as standard of care in both the arms, then it has to be safe. So one can definitely go ahead with that if there is no gross tumor in and around the hippocampus.
Thank you.
Any other question? So,
Okay, thank you.
if there is no question, we can conclude this session. Thank you. Thank you, Dodul.